Welcome, curious minds, to another deep dive. If there's one field that touches every single one of our lives, yet remains incredibly complex, it's definitely healthcare.
Oh, absolutely. It's a huge topic. We all interact with it. Doctors, nurses, clinics, hospitals.
Exactly. But what about the invisible backbone, the intricate systems that make it all tick behind the scenes? That's what we're getting into today.
It really is a vast, interconnected ecosystem. And today, our mission really is to try and untangle some of that complexity for you.
Yeah, we're diving deep into understanding this intricate world of healthcare information and management systems.
And it's important to remember this isn't just about the frontline providers, the doctors and nurses you see. It's about the vital flow of information, the cutting-edge technology that supports it all.
And the dedicated professionals who actually make sure it works seamlessly, or as seamlessly as possible in such a complex area.
Right. It's a huge undertaking.
So our goal for you, the listener, is to provide a kind of shortcut, a way to get well informed about this entire incredibly complex healthcare environment.
We'll be looking at the organizations involved, the massive amounts of data that underpin, well, everything.
And the specific roles people play in driving efficiency and quality. We're hoping for some surprising facts and definitely some of those aha moments for you.
Definitely. And just so you know where this is coming from, this deep dive is built on a collection of pretty comprehensive sources. They really lay out the healthcare environment, the essential information systems, and all the dynamic roles within this crucial field.
We've sifted through them and pulled out what we think are the most important nuggets for you to grasp.
Okay, so where do we start? Maybe with the fundamental idea of what health even means in this context.
Yeah, let's kick off with the definition that I find this amazing. It's from 1948, but it's still revolutionizing healthcare today.
You're talking about the World Health Organization's definition.
Exactly. The WHO's idea that health isn't just about, not being sick. It's defined as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity.
That's such a key distinction, complete well-being, physical, mental, and social.
Right. And what's truly surprising, I think, is how this seemingly simple decades-old definition is now the driving force behind this massive shift we're seeing in modern healthcare.
A shift away from just treating advanced illness.
Towards investing, billions in prevention and this idea of holistic wellness.
It fundamentally changes everything. Where care happens, how it's delivered.
So we're moving beyond just the traditional doctor's office visits and hospital stays.
Yeah, much more focused now on wellness encounters, virtual encounters, think telehealth, video calls with your doctor.
Mobile health, too. Apps, wearables.
Right, and even preventive care outreach.
Yeah.
Health systems actively reaching out to people before they get seriously ill.
And a big driver for this, let's be honest, is the economics. This reevaluation is being pushed hard by the very real pressure of healthcare costs.
Oh, definitely. The strain on national economies is immense. Healthcare spending is a huge chunk of GDP in many countries.
Which brings us to just how exceptionally complex this environment is. It's like a constant balancing act, isn't it?
It really is. You often hear about the four pillars: quality, access, cost, and value.
And trying to maximize all four simultaneously?
Oh, yeah.
Well, it's almost impossible. There are always trade-offs.
Exactly. Healthcare professionals are under constant pressure. Deliver the highest quality care, make it accessible to the greatest number of people, keep costs under control, and demonstrate value. It's a lot.
And it's not just the doctors and nurses feeling the pressure. You mentioned stakeholders earlier.
Yeah, the demands come from all sides. You've got governments setting policies and budgets.
Consumer groups advocating for patients. Professional associations representing doctors, nurses, administrators.
Regulatory organizations setting standards. Then the payers, the insurance companies, government programs, they have huge influence.
And don't forget the suppliers, pharma companies, medical device manufacturers. Everyone has a stake and is pulling in sometimes different directions.
It creates this incredibly dynamic, high-pressure environment. And the spending figures really highlight that. You mentioned the OECD data.
Yeah, the variance globally is pretty stark. The U.S., for instance, spending around 17% of its GDP on health consumption back in 2017.
Compare that to, say, Switzerland, which was around 12%. Still high, but a significant difference.
And that 17% figure in the U.S., it's widely seen as unsustainable. It's not just a number. It's the economic imperative driving governments worldwide to really engage in changing health programs, trying to find ways to deliver affordable, quality care.
Absolutely. It's forcing a global rethink.
Yeah.
Australia focusing on primary care, Canada experimenting with privatization, Germany using budgeting controls, Japan tackling long-term care payments, the UK trying pro-market reforms.
And the U.S., with things like accountable care organizations, which we'll probably touch on later, it's a global challenge.
So that gives us the big picture, the sort of macro view, the pressures and the definition of health we're working with.
Okay, so with that foundation, let's zoom in a bit. Where does all this complex care actually happen? Let's look at it from the patient's perspective. What kinds of organizations are providing care?
Right. Well, the most obvious one probably is the hospital. That's where you typically go for inpatient care staying overnight or longer.
And hospitals themselves aren't monolithic. They come in different flavors.
Definitely. You can classify them in several ways. One big one is ownership.
Like public versus private.
Exactly. Or for-profit versus nonprofit. In the U.S., you have large investor-owned systems like HCA Healthcare. In the UK, you might see private groups like BMI Healthcare alongside the NHS.
In places like Canada, nonprofit hospitals are much more the norm, often run by community boards or religious organizations.
Right. Then there's the type of service they offer. Is it a general hospital, treating a wide range of conditions?
Or is it a specialty hospital, focusing on, say, psychiatric care, rehabilitation, or maybe children's health?
Then there's teaching status. Is it an academic medical center, a university hospital? These places often handle the most complex cases and are hubs for medical research.
That's a really important function, the research and teaching aspect.
Absolutely. And finally, geographic location matters too. Urban hospitals face different challenges and have different funding streams compared to rural hospitals.
Yeah, rural healthcare has its own unique set of issues, like attracting staff and funding. We see things like critical access hospitals in the U.S. specifically designed to support those areas.
Okay, so hospitals are the big inpatient centers. But a huge trend, as we mentioned, is the shift away from hospitals where possible.
Towards outpatient or ambulatory care, why is that shift happening so strongly?
Well, two main reasons, really. Cost and convenience. It's generally less expensive to provide care in an outpatient setting.
No overnight stays, less intensive resources needed.
Right. And from the patient's perspective, it's often much more convenient and less disruptive to their lives. Patient friendliness is a big driver.
So what falls under this outpatient umbrella?
A whole range of things. Your regular primary care visits, seeing your family doctor, specialist referrals, going to see a cardiologist or a dermatologist, for example.
And even surgeries now?
Yes, definitely. Many less complicated surgeries that used to require a hospital stay are now routinely done in ambulatory surgery centers, or ASCs. You go in, have the procedure, and go home the same day.
That's a massive change from, say, 20 or 30 years ago.
Huge change. And it continues to evolve. Think about urgent care clinics.
Right, for things that aren't life-threatening emergencies but need quicker attention than waiting for a regular doctor's appointment.
Exactly. And even those minute clinics you sometimes see inside drugstores or supermarkets for very basic things, like vaccinations or treating minor infections.
It really speaks to that demand we talked about earlier, the always-on, always-available expectation from patients.
It does. Patients increasingly want to book appointments directly online, maybe see reviews, and even have virtual visits via video calls for certain issues. The expectation for seamless digital access is growing.
Okay, so hospitals, outpatient ambulatory care. What else?
Well, there are also community health organizations. The idea of community here usually refers to a specific geographic location or sometimes a specific population group.
Can you give an example?
Sure. Canada has community health centers, CHCs. They often aim to provide comprehensive primary care, including health promotion and disease prevention, tailored to the needs of their local community. They often serve areas that might be medically underserved.
And I mentioned the critical access hospitals in the U.S. earlier. Those are specifically for rural, underserved areas, too, keeping essential services local.
Exactly. And then kind of supporting all these different care settings, you have what are often called ancillary services.
Ancillary, meaning?
Meaning supplementary or supporting services.
Yeah.
Think about diagnostic services, laboratory tests, imaging like X-rays or MRIs, radiology.
Right. Most doctors' offices don't have their own MRI machine.
Precisely. They rely on external providers for those specialized tests. And pharmaceutical services pharmacies are crucial too, providing the medications prescribed by doctors.
So for comprehensive care to happen, all these different players, hospitals, outpatient clinics, community orgs, diagnostic centers, pharmacies, they all need to work together somehow.
Absolutely. Which brings us back to that theme of interrelationships and information flow. But before we get there, maybe we should tackle the money side.
Ah, yes, the million-dollar question, or rather the multi-trillion-dollar question. How does all this actually get paid for? You mentioned it's incredibly complex.
It really is. The payment landscape varies hugely around the world. But generally, payments come from, let's say, three main types of entities.
Okay, what's the first type?
First, you have government-financed and managed programs. This is where the government is the primary payer.
So like single-payer systems.
Exactly. The UK's National Health Service, the NHS, is a classic example. The government funds healthcare through taxes and manages the delivery of most services.
What about other government models?
There are also national health insurance programs, like in Canada. The government finances healthcare through taxes, but the actual delivery of care might be through a mix of public and private providers. The government acts as the insurer for everyone.
And then there's the U.S. model.
Which is, well, famously complex. It's a multi-payer system, but with significant government involvement. You have Medicare, the federal program primarily for people aged 65 and older.
And Medicaid.
Medicaid is a joint federal and state program providing coverage for many low-income individuals and families. And there's also CPHIMS, the Children's Health Insurance Program for uninsured children and families who earn too much to qualify for Medicaid but can't afford private insurance.
So even within the government category, there's a lot of variation.
A huge amount. Okay, so that's government programs. What's the second category?
That would be insurance programs administered by private entities. Right. This is where private companies manage the insurance plans. Yeah. The funding might come from employers who offer health insurance as a benefit to their employees, or individuals might purchase plans directly from an insurer.
This is very common in the U.S., the employer-based system.
Very common. But you see private insurance elsewhere, too. In Germany, for instance, there's a system based on sickness funds, which are nonprofit entities. Employers and employees both contribute.
And even in countries with strong national health systems, like the UK or Canada, people might still buy private insurance, right?
Yes, often to cover services that aren't included in the national plan, maybe certain dental procedures or physiotherapy, or sometimes to get faster access to elective surgeries, bypassing public system waiting lists.
Okay, so government payers, private insurers. What's a third source of payment?
Personal funds.
Oh.
People paying directly out of their own pockets.
You mean like co-payments?
Co-payments are a big part of it, yes. That fixed amount you might pay for a doctor's visit or a prescription, even when you have insurance. And co-pays seem to be becoming more common globally as a way to manage costs.
And then there are people who just pay the whole bill themselves, cash payers.
Yes, although that's less common in systems with universal coverage. But it definitely happens.
Mm-hmm.
And this brings us to a particularly difficult situation, especially prominent in the U.S.
What's that?
It's the situation for people who fall through the cracks. They don't qualify for government programs like Medicaid, perhaps because their income is slightly too high.
But they can't afford to buy private insurance on their own, or their employer doesn't offer it.
Exactly. And these individuals, if they need health care, often face the highest prices, the non-negotiated list prices from hospitals and providers, which can be exorbitant.
And this contributes to medical debt.
Massively. It's a major driver of medical bankruptcy in the U.S. One study looking at bankruptcies between 2013 and 2016 found that something like 2/3, 66.5%, were tied to medical issues, either the cost of care itself or time lost from work due to illness.
That's staggering. Did the Affordable Care Act, ACA, help with that?
The ACA aimed to reduce the number of uninsured people, and it did help millions gain coverage. However, studies suggest its impact on medical bankruptcy rates specifically was perhaps more limited than hoped. High deductibles and out-of-pocket costs can still be a major burden, even for those with insurance.
Wow. It just highlights how complex managing the money side is for everyone involved.
Absolutely, and think about it from the perspective of a hospital or a clinic. Managing their accounts receivable, the money they're owed for services, is an incredibly complex task.
Because they're dealing with so many different payers.
Exactly. Medicare, Medicaid, dozens of different private insurance plans, each with different rules, different coverage levels, different reimbursement rates, different billing requirements, plus patient copays and deductibles. It's a huge administrative burden.
Okay, so that complexity in payment really underscores why the next topic is so crucial, the interrelationships between all these different healthcare organizations.
Yes. They don't operate in isolation. They have to connect and communicate effectively.
Why are these connections so vital? What do they enable?
Well, several key things. First, just achieving comprehensive care for a patient. We touched on this. Your primary doctor needs lab results, maybe imaging reports, information from specialists.
Right, you can't treat the whole person if you only have one piece of the puzzle.
Precisely. Effective transfers of care are another huge one. When a patient moves, say, from a hospital back home with home health services, or from a hospital to a rehab facility.
Portability of information, being able to access health info when you travel.
Crucial. Public health reporting relies on data flowing from providers to public health agencies.
Getting reimbursed, we just talked about how complex that is. It requires sending claims data.
Definitely. And finally, these interrelationships are essential for supporting new models of care that aim to be more coordinated and efficient.
Okay, let's unpack a few of those. Starting with comprehensive care. How does technology play into preventing care breakdowns?
Technology is increasingly the key. Historically, information was shared via paper records, phone calls, faxes, which is slow and prone to errors or things getting lost.
I can imagine. A fax gets misplaced, a message isn't passed on.
Exactly. Now, the push is towards electronic systems sharing data directly. And the key word here, the holy grail, really is interoperability.
Interoperability. We hear that word a lot. What does it actually mean in practice?
It means different computer systems from different vendors used by different organizations can exchange health information, and the receiving system can actually understand and use that information meaningfully. It's not just about sending data. It's about sending data that can be instantly incorporated into the workflow on the other end.
So it avoids someone having to manually re-enter information, reducing errors.
Yes, and it makes the relevant information available to the clinician right when they need it within their own system. It prevents those breakdowns where, say, a crucial allergy documented in the hospital system isn't visible to the pharmacy system.
That sounds critical for patient safety.
It absolutely is,
Ugh.
which leads nicely into the next point, effective transfers of care.
When a patient moves between settings.
Right. Imagine being discharged from the hospital. If the primary care doctor you're seeing next week doesn't have a complete summary of your hospital stay, your diagnosis, procedures, test results, changes in medication, what happens?
Well, time gets wasted explaining everything again. Maybe tests get repeated unnecessarily.
Exactly. Lost time, repetitive evaluations, maybe even repeating uncomfortable or invasive tests because the results weren't available. It's inefficient and frustrating for everyone.
So how are systems trying to improve this transfer of information?
There are standards being developed and promoted. In the U.S., for example, there's a big push to use a standard called HL7 Consolidated Clinical Document Architecture, or CCDA.
CCDA?
Yeah, it defines a standard electronic format for things like discharge summaries or continuity of care documents, making it easier for different systems to share and interpret that core information needed during a transition.
And you mentioned medication earlier. That seems like a really high-risk area during transfers.
It is. One of the most critical processes during any transfer of care is medication reconciliation.
Reconciliation, like balancing a checkbook.
Kind of. It's the process of creating the single most accurate list possible of all medications a patient is actually taking, including prescription drugs, over-the-counter medications, supplements, everything, and comparing that list against what's being ordered or prescribed at the point of transfer.
To catch any discrepancies, like duplications, omissions, potential interactions.
Exactly. Errors in medication orders are unfortunately common during transitions, and they can have serious consequences. So, thorough medication reconciliation, often aided by technology but requiring careful clinical review, is absolutely vital for patient safety.
Okay, so seamless info exchange is key for comprehensive care and safe transfers. What about that portability point? Accessing info when traveling.
Yeah, think about it. You're on vacation, maybe even in another country, and you get sick or have an accident, you end up in an emergency room where nobody knows your medical history.
That sounds scary. They wouldn't know your allergies, your existing conditions, the medications you take.
Precisely. Being able to access even a basic summary of your critical health information in that situation could be life-saving. It can profoundly influence treatment decisions.
So are there systems being built to allow this?
Yes, many countries are working on or have implemented national or regional health information exchanges, HIEs. The idea is to create networks that allow authorized providers to securely access patient information when and where it's needed, regardless of where the patient usually receives care.
Can you give some examples?
Sure. Canada has Canada Health Infoway, which works towards creating a national system for electronic health records. The UK has NHS Digital, working on similar goals for England's health and care system. In the U.S., there isn't a single national system, but there's the concept of the Nationwide Health Information Network, NHIN, now often referred to as eHealth Exchange, connecting various regional and state HIEs and federal agencies.
So the goal is virtual, real-time access when needed, respecting privacy, of course.
That's the vision. It's complex to implement, technically and politically, but the potential benefits for patient care are huge.
Okay, so we've talked about information flow for individual patient care, but you mentioned other uses too, like public health.
Yes, this is often called the secondary use of health information. The primary use is treating the patient directly. The secondary use is leveraging aggregated, often de-identified, health data for broader purposes.
Like tracking disease outbreaks.
Exactly. Public health agencies rely on reports from hospitals and labs to spot trends, identify outbreaks early, and monitor the health of the population. Think about tracking flu cases each winter, or monitoring rates of chronic diseases like diabetes.
So health systems report certain data to public health authorities.
Yes, often mandated reporting for specific infectious diseases. But secondary use also supports research understanding disease patterns, evaluating treatment effectiveness across large populations. And it helps with health system management planning services, allocating resources based on community needs identified through data.
Are there specific systems for this?
Some countries have dedicated platforms. The UK's Secondary Uses Service, SUS, is an example. It provides access to anonymized hospital data for purposes beyond direct care, like research and planning. In the U.S., the Centers for Disease Control and Prevention, CDC, conducts extensive surveillance, using data from various sources to monitor public health proactively and reactively.
Okay, that makes sense. What about reimbursement? How does information flow tie into getting paid?
Well, at its most basic, providers need to submit claims to payers, the government programs or insurance companies detailing the services they provided in order to get paid.
And that requires specific information, specific codes for diagnoses and procedures.
Precisely. It's a massive flow of administrative and clinical data. And as we discussed, it's incredibly complex in multi-payer systems like the U.S., where each payer might have slightly different requirements.
But it's moving beyond just paying for doing things, right? Towards paying for quality.
Yes, that's a major trend. Governments and large employers, who foot a lot of the healthcare bill, are increasingly trying to link reimbursement to the quality and value of care provided, not just the volume of services.
How do they measure quality and value using information systems?
They use data submitted by providers on specific quality metrics. For example, did heart attack patients receive aspirin upon arrival? What are the hospital's readmission rates for certain conditions? What are patient satisfaction scores?
So providers report this data, and it affects their payment.
Increasingly, yes. There are various incentive programs. In the U.S., the Centers for Medicare and Medicaid Services, CMS, has the Merit-Based Incentive Payment System, MIPS, for physicians, which adjusts Medicare payments based on performance and quality, cost, promoting interoperability and improvement activities.
Are there private initiatives too?
Yes. Organizations like the Leapfrog Group in the U.S. collect and report hospital quality and safety data, often used by employers and consumers. The underlying idea is to incentivize better outcomes and link those improved outcomes with the overall cost of care, make the system more efficient and effective.
And all of this relies heavily on robust information systems to collect, analyze, and report that data accurately.
Absolutely fundamental. You can't manage or improve what you can't measure.
Okay, and the last point you mentioned about interrelationships was supporting new organizational models of care.
Right. As healthcare tries to become more coordinated and manage costs better, new structures are emerging that inherently rely on strong information sharing.
Like what?
Well, one concept is the Integrated Delivery System, or IDS. This is where different healthcare organizations, maybe a hospital, physician groups, outpatient clinics, home health agencies, come together under some form of common ownership or close coordination.
The goal being to provide a seamless continuum of services to the patient.
Exactly. Managing the patient's journey across different settings, keeping everyone informed, avoiding duplication, focusing on prevention, all ideally leading to better quality and lower costs.
And this requires tight integration of their information systems.
Essential. For an IDS to work effectively, patient information needs to flow smoothly between all the participating entities.
And then there are ACOs, you mentioned them earlier.
Yes, Accountable Care Organizations, or ACOs. This model was particularly codified and encouraged by the Affordable Care Act in the U.S., specifically for the Medicare program, although the concept exists more broadly.
How do they work?
Basically, a group of providers, hospitals, primary care physicians, specialists, agree to take collective responsibility for the overall quality and cost of care for a defined population of patients, initially Medicare beneficiaries.
So they work together to keep patients healthy and manage chronic conditions effectively.
That's the idea. If they succeed in providing high-quality care and reducing the total cost of care for their assigned patients below certain benchmarks.
They get to share in the savings.
Exactly. They share some of the savings they achieve for the Medicare program, but crucially, they also have to meet specific quality targets. It's not just about cutting costs. It's about delivering better care more efficiently.
And that sounds incredibly information intensive. They need data on all their patients across all settings, track quality measures, analyze costs.
Absolutely. Running an ACO effectively requires sophisticated health IT infrastructure, data analytics capabilities, and seamless information sharing among all the participating providers. It's a prime example of how these interrelationships and the information systems enabling them are critical for new value-based care models.
Wow. So it's clear that underneath all this complexity, the different organizations, the payment systems, the need for coordinated care, there's this layer of information and technology making it all happen.
Or trying to make it happen. It's a constant work in progress.
Which leads us naturally to the people involved, the professionals who actually design, build, manage, and protect all these vital systems.
Yes, the architects and guardians of health information, you could say. They are absolutely essential, often the unsung heroes working behind the scenes.
And this isn't just one job title, is it? You mentioned a wide variety.
Oh, huge variety. The field of health information management, often called HIM, and health information technology, HIT, or sometimes just health IT, encompasses a vast range of positions.
It must vary depending on the size of the organization.
Tremendously.
Huh.
In a small, single-provider doctor's office, you might have one person who handles billing, scheduling, managing the electronic record system, maybe basic IT troubleshooting, wearing many hats.
Whereas in a large academic medical center,
You could have an IT department with over 100 people, maybe many more, with highly specialized roles covering everything from network infrastructure to clinical application support to cybersecurity to data analytics.
so let's talk about some of the key roles, maybe starting at the leadership level in larger organizations. What kind of positions do we see?
Okay. At the top, you often find a Chief Information Officer, the CIO.
What's their responsibility?
The CIO is typically accountable for the overall information technology strategy and operations of the organization. That's a broad scope overseeing the data centers, computer networks, desktop computers, telecommunications, mobile devices, maybe even Internet of Things, IoT devices, used in care, the organization's website, core IT infrastructure.
So keeping the lights on, technologically speaking, and planning for the future.
Pretty much. Making sure the technology supports the organization's strategic goals. Then, increasingly crucial, you have the Chief Security Officer, or CSO.
Focus purely on security.
Yes. Their job is to protect all the organization's computing and communication assets. The systems, the data from threats like data breaches, ransomware attacks, unauthorized access. It's a massive responsibility, especially in healthcare, with sensitive patient data.
Are there specific credentials for this role?
Often, yes. You might see CSOs holding advanced security certifications, like the Certified Information Systems Security Professional, or CISSP.
Okay, CIO for overall IT, CSO for security. What about privacy? That's huge in healthcare, too.
Absolutely critical. There's usually a designated privacy officer. Their focus is ensuring that personally identifiable information, especially protected health information, or PHI.
PHI, that's the term used under IPAY in the U.S., right?
Exactly. The privacy officer ensures PHI is accessed, used, and disclosed only by authorized individuals and for authorized purposes in compliance with privacy laws like HIPAY in the U.S. or similar regulations elsewhere like GDPR in Europe.
So they set policies, conduct training, investigate potential breaches.
Yes, all of that. They often work very closely with the security team, but their focus is specifically on the data privacy rules and regulations. There are specialized certifications here too, like the Certified in Healthcare Privacy and Security, CHPS.
Interesting. Any other key C-suite roles related to tech?
Another one you sometimes see is the Chief Technology Officer, or CTO.
How's that different from the CIO? The title sounds similar.
There can be overlap, and the structure varies. But often where a CTO exists, they might be more focused on the technical architecture and future technology. Evaluating emerging tech like new mobile platforms, cloud computing strategies, advanced clinical applications, and figuring out how to integrate them effectively to keep the organization competitive and innovative.
So, CIO, more strategy and operations, CTO, more technical vision and implementation.
That's one way to think about it, though roles can blend. Okay, so those are some top leadership roles. Moving down a level, but still incredibly important, are roles bridging IT and the clinical or administrative side.
Like health information managers. You mentioned him earlier.
Yes, HIM professionals. Historically, their domain was the paper medical record department, organizing records, ensuring completeness, maybe coding for billing.
But that's changed dramatically with electronic records, hasn't it?
Completely. With the widespread adoption of electronic health records, or EHRs, HIM professionals are now absolutely central to many IT activities. Their expertise in health data content, structure, quality, privacy, and the legal aspects of the health record is indispensable.
So they're involved in managing the EHR system itself.
Often, yes. Overseeing data quality, managing coding and reimbursement processes, which are now electronic, ensuring compliance with regulations related to health information, managing access controls, supporting audits. Their role is incredibly broad now.
Are there credentials for him professionals too?
Yes, definitely. In the U.S., common ones are the Registered Health Information Administrator, RHIA, which usually requires a bachelor's degree, and the Registered Health Information Technologist, RHIT, typically associated with an associate's degree. Canada has a certification in Health Information Management, CPHIMS designation.
Okay, so him focuses on the management and integrity of the health information itself. What about connecting IT with the doctors and nurses using the systems?
That's where clinical informatics comes in. This field has exploded as medicine becomes more reliant on EHRs and other health information systems.
What does a clinical informaticist do?
They bridge the gap between clinical practice and information technology. They understand clinical workflows, how doctors and nurses actually work and think, and they apply that understanding to help design, implement, and optimize IT systems so they actually help clinicians provide better care rather than hinder them.
That sounds like a crucial role. Getting clinician buy-in and making systems usable must be key.
Absolutely. In fact, the American Medical Informatics Association, AMIA, has been advocating for clinical informatics to be recognized as a formal medical subspecialty, highlighting its importance.
So are there specific job titles in this area?
Yes, you often see leadership roles like Chief Medical Information Officer, CMIO, usually a physician with informatics training, or Chief Nursing Informatics Officer, CNIO, a nurse leader with similar expertise. Sometimes there's a Chief Health Information Officer, CHIO, overseeing both or focusing broadly on clinical data strategy.
And these roles are really important for making sure the technology actually meets the needs of the clinicians on the ground.
Critical important. They translate between the IT world and the clinical world, ensuring systems are designed and implemented effectively, training users, and championing the use of technology to improve care quality and safety.
Okay, so we have leadership, HEAP, clinical informatics. What about the more traditional IT roles? Do healthcare organizations need those too?
Oh, absolutely. They need the full spectrum of IT professionals that any large organization would need, but often with some added healthcare-specific knowledge.
Like what type of roles?
You'll find desktop support technicians keeping computers running, database administrators managing the vast amounts of data, programmers developing or customizing software, web developers managing internal and external websites.
Network engineers keeping the communication lines open.
Exactly.
Yeah.
Systems analysts figuring out requirements for new systems or upgrades, project managers overseeing IT implementations, security analysts working under the CSO to monitor threats and implement security controls. The list goes on.
So it's a diverse team needed to keep everything running smoothly.
Definitely. A complex ecosystem requires a complex support structure.
Now, this brings us to a really interesting point, and something I think can be confusing for people. We've thrown around terms like health informatics, health information management, and we hear a lot about data science these days. How do these three fields relate or differ, especially within healthcare?
That's a great question. And yeah, there's definitely overlap and potential for confusion. Let's try to break it down to maybe think of it with an analogy.
Okay, I like analogies.
Let's start with data science. Think of a data scientist as someone who builds incredibly powerful, versatile engines. Their focus is on the core methods, the math, the statistics, the computer science, machine learning, deep learning algorithms.
So they're experts in extracting knowledge and actionable insights from huge amounts of data, any data.
Pretty much. Data science is a multidisciplinary approach used across many industries: finance, manufacturing, retail, you name it. They prepare data, analyze it, build predictive models, and present results to reveal patterns and enable informed decisions. They need strong programming skills, stats knowledge, data mining expertise.
Okay, so data science is the foundational engine-building expertise for large-scale data analysis. How does health informatics fit in?
If data science builds the powerful engine, health informatics is like designing a specialized vehicle, say, a highly optimized ambulance, or a mobile diagnostic unit specifically for healthcare using that engine.
Ah, so it's applying those data science principles within the healthcare context.
Exactly. Health informatics is often described as the human side of data science applied to healthcare. It's inherently interdisciplinary, blending knowledge of health services, information technology, and medical science.
So what's the goal of health informatics?
The goal is really to help healthcare providers, managers, and policymakers use data and technology to optimize healthcare outcomes, improve performance, streamline workflows, and advance medical knowledge. They're asking the question, okay, we have all this health data. What can we do with it from a design and analysis perspective to make things better?
So they might be involved in designing how EHRs collect data, or analyzing clinical data to identify best practices, or developing clinical decision support tools.
Yes, all of those are classic health informatics activities. It's focused on the intersection of information, technology, and healthcare delivery, how to leverage data and systems effectively at a systemic level.
Okay, that makes sense. Data science core engine, health informatics designing the specialized healthcare vehicle using the engine. So where does health information management fit into this analogy?
HIMSS professionals are the highly skilled, licensed drivers and meticulous maintenance crew for that specialized healthcare vehicle.
Ah, so while informatics is focused on the design and analysis, developing the data tools and figuring out what can be done,
HIMSS is focused on the actual application, the day-to-day operation, management, and protection of those systems, and the information within them.
so HIM is more about the practical operational side.
Yes, very much so. Remember the formal definition. HIMSS is the practice of acquiring, analyzing, and protecting digital and traditional medical information vital to providing quality patient care.
Acquiring, analyzing, protecting.
Right. Their responsibilities are grounded in the immediate needs of patient care and organizational operations. Managing patient data accuracy and completeness in the EHR. Applying standardized codes to diagnoses and procedures for accurate reimbursement.
Ensuring the organization complies with all the complex healthcare regulations.
Making sure doctors, nurses, and other staff have the right access to the information they need to do their jobs, but no more than they need.
And critically, protecting the security and privacy of that incredibly sensitive patient information on a daily basis.
Exactly. So the core difference really boils down to this. Health informatics tends to focus more on the behind-the-scenes design, development, and analysis. How can we build better systems and leverage data strategically?
While health information management focuses more on the practical and immediate impact on patient care through the effective use, management, and protection of those systems and the data they contain.
Precisely. Informatics is often about developing the tools and insights. HIMSS is about using and safeguarding those tools and the resulting information in the real world, ensuring quality, compliance, and security.
That's a really helpful distinction. So for you, the listener, if you're thinking about this field, the choice might depend on your interests.
Right. Are you more fascinated by the science and theory behind data collection, analysis, and leverage? The design of systems, the potential of algorithms? That might steer you towards health informatics, or even data science applied to health.
Or are you more drawn to the hands-on application? Using these systems directly to support patient care, ensuring data integrity, managing operations, protecting information, navigating regulations. That aligns more closely with health information management.
And it's important to say, both are absolutely critical. You need the diviners and analysts, and you need the expert operators and guardians. They often work very closely together.
That makes perfect sense. Okay, so we have the people, the roles, the systems. What about the governance structures overseeing all this? We touched on governments and regulators earlier.
Yes, and it's worth circling back to that because the role of government and regulatory bodies is particularly pronounced in healthcare compared to many other sectors.
Why is that? Because it's so important and so expensive.
Exactly, those two reasons. Healthcare is fundamental to societal well-being. And as we've discussed, it consumes a massive chunk of national resources. So governments inevitably get heavily involved in policy, funding, and regulation.
And we mentioned countries grappling with rising GDP consumption.
Right. This forces governments everywhere to make difficult policy decisions. We talked about examples like Germany using global budgeting for hospitals, giving them a fixed annual budget to encourage efficiency.
Or Canada experimenting with different levels of private delivery within its publicly funded system. The UK's NHS constantly undergoing reforms.
Japan dealing with the costs of an aging population and long-term care. Australia focusing on strengthening primary care. The U.S. trying models like ACOs to control Medicare costs. It's a constant balancing act for policymakers.
So governments set the broad policies and often control significant funding streams. How do regulations come into play?
Regulatory agencies are typically responsible for implementing the health laws passed by governments. They create the specific rules and standards that healthcare organizations and professionals have to follow.
Can you give some examples of these regulators?
Sure. In the UK, you have bodies like the Health and Care Professions Council, HCPC, which regulates various health professionals. In the U.S., the Department of Health and Human Services, HHS, is huge, encompassing agencies like the Centers for Medicare and Medicaid Services, CMS.
CMS must be incredibly influential given the size of Medicare and Medicaid.
Hugely influential. Their rules regarding billing, quality reporting, and information technology adoption shape behavior across the entire U.S. healthcare system, even for private payers who often follow Medicare's lead.
What about things like drug safety or medical devices?
That falls under the Food and Drug Administration, FDA in the U.S., another key regulatory body within HHS. They oversee the approval and monitoring of pharmaceuticals and medical devices.
And it's not always government agencies acting as regulators, is it?
That's true. Sometimes private sector organizations can also act in a regulatory or quasi-regulatory capacity, perhaps by setting standards that become widely adopted or are required for participation in certain programs.
Okay, so governments set policy, regulators implement rules. What about professional associations? Where do they fit in?
Professional associations are different from regulatory bodies. Their primary focus is usually on serving their members.
So organizations like the American Health Information Management Association, OHIMA, or HIMSS, which we'll talk more about, or the American Medical Informatics Association, AMIA.
Exactly. They typically advocate for the interests of their members and the profession as a whole. They promote the profession, provide continuing education and professional development opportunities, publish journals, hold conferences, maybe offer certifications.
How does that contrast with the role of a regulatory body?
The primary role of a regulatory body is generally to protect the public. They do this by setting minimum standards for entering a profession, like licensing requirements, defining scopes of practice, establishing codes of ethics, and investigating complaints against professionals. Their allegiance is to public safety, whereas the association's focus is more on the profession itself.
That's a key distinction. Public protection versus profession advancement, although the goals can overlap.
They definitely can. Both want competent, ethical professionals, but their primary mandates are different.
Okay, one more category often mentioned in healthcare oversight. Accreditation organizations, or AOs, what do they do?
AOs play a sort of semi-regulatory role. They are often private, nonprofit organizations that develop standards of quality and safety for healthcare organizations.
And hospitals or clinics voluntarily seek accreditation from them.
Usually, yes, but it's often quasi-voluntary because accreditation might be required to receive payment from Medicare or major insurance companies, or it might be needed for state licensure. So it functions a bit like regulation.
Are there well-known AOs?
Yes. The Joint Commission is probably the most well-known in the U.S. for accrediting hospitals and other healthcare organizations. They also have an international arm, Joint Commission International, JCI.
And CMS actually approves certain AOs.
Right. CMS can grant deeming authority to certain AOs, meaning if an organization achieves accreditation from that AO, it's deemed to meet the Medicare conditions of participation. Examples include the AAAHC, Accreditation Association for Ambulatory Healthcare, and ACHC, Accreditation Commission for Healthcare, among others. This avoids duplicate inspections by both the state CMS and the AO.
Wow, so you have government, regulators, professional associations, and accreditation organizations all interacting.
It's a complex web. The interrelationships among all these different agencies, associations, and regulators can be surprisingly intricate. The path for even a single career, like becoming a physician assistant, involves navigating requirements from educational accreditation bodies, state licensing boards, national certification organizations, and the regulations of the facilities where they work. It's layered.
Definitely sounds layered. Okay, you mentioned HIMSS earlier as a professional association. Let's zoom in on them as they're quite prominent in the health IT space. What exactly is HIMSS?
HIMSS stands for the Healthcare Information and Management Systems Society. They describe themselves as a global advisor, thought leader, and member association committed to transforming the health ecosystem.
That's a broad mission. What do they actually do?
They're a nonprofit organization, and they really focus on health innovation, public policy related to health IT, workforce development in this field, research and analytics. They run major conferences, publish information, offer educational programs, and work to connect various stakeholders in the health technology world.
So they're trying to drive the adoption and effective use of information and technology in healthcare.
Exactly. They've been around for over 60 years, serving the global health community. They advise leaders, healthcare organizations, and even governments on best practices, trying to ensure people have the right information and technology available at the point of decision-making to improve health outcomes.
And they offer certifications as well.
Yes, they do. One of their key credentials, particularly relevant to our discussion today, is the CPHIMSS certification.
CPHIMS, what does that stand for?
Certified Professional in Healthcare Information and Management Systems.
And who is this certification aimed at?
It's designed for experienced professionals working in healthcare information and management systems, essentially. Health IT staff working within healthcare settings, or for vendors serving the healthcare industry. It's a way for them to demonstrate broad knowledge and competence across the field.
So it's not just for managers. It could be for analysts, project managers, implementers.
Correct. It covers a wide range of common knowledge and skills needed in various health IT roles. It signifies a certain level of experience and understanding of the healthcare environment, technology systems, and management principles specific to this sector.
What does it take to be eligible to even sit for the CPAIMS exam? Is it just for beginners?
No, definitely not for beginners. It requires a combination of education and experience. There are basically 3 pathways to eligibility.
Okay, what are they?
First, if you have a baccalaureate degree, you need at least 5 years of experience in information and management systems, and importantly, at least 3 of those years must be specifically within the healthcare environment.
Okay, bachelor's plus 5 years, 3 in healthcare. What's the second path?
If you have a graduate degree, like a master's or PhD, the experience requirement is lower. 3 years of information and management systems experience, with at least 2 of those years in healthcare.
So higher degree means slightly less work experience needed. Makes sense. Is there a path for those without a degree?
Yes, there's a third pathway based purely on experience. If you don't have a relevant degree, you need 10 years of documented experience in information and management systems, and crucially, 8 of those 10 years must have been in healthcare.
10 years, 8 in healthcare. So significant real-world experience is key across all paths.
Absolutely. It's meant to certify professionals who have already been working in the field for some time.
What's the exam itself like?
It's a multiple-choice exam. Currently, it's 2 hours long and consists of 115 questions. Only 100 of those are scored. The other 15 are pre-test questions being evaluated for future exams.
And what kind of topics does it cover? Is it super technical?
It covers a broad range, focusing on common knowledge and skills. HIMSS outlines the content in several key domains. They have review programs and materials based on these domains.
What are those main domains?
The main areas covered typically include the overall healthcare and technology environments, understanding the context we've been discussing, clinical informatics, bridging clinical care and IT, healthcare information and systems management. This is a big one.
What's under that umbrella?
It covers the whole life cycle: analysis, design, selection, implementation, support and maintenance, testing and evaluation, and critically, privacy and security.
So the practical aspects of managing health IT systems.
Exactly. And the final domain is management and leadership, covering aspects like project management, strategic planning, communication, and leadership within the health IT context.
So it really aims for a comprehensive understanding of the field.
That's the goal. It's not just testing technical skills, but also understanding the healthcare environment, the clinical context, and the management aspects needed to be effective.
How long is the certification valid for? Do you have to retake the exam?
The CPM certification is valid for 3 years. To maintain it, you don't necessarily have to retake the exam. Instead, you need to complete 45 hours of continuing education, CE, during that 3-year cycle.
So keeping your knowledge current is important.
Yes. Although it's worth noting, they had some waivers related to specific HIMSS activities due to the pandemic, but generally, ongoing professional development is required for renewal.
Okay, so if someone goes through the CPM's review program, what are the main things they should expect to learn or be able to do?
Well, the learning objectives aim to ensure candidates can understand the different types of healthcare organizations and their complex interrelationships, much like we've discussed today.
understand the roles of the various professionals involved.
Yes, and the overall opportunities and challenges within the healthcare environment. They should be able to speak the basic language, have a grasp of clinical and health IT vocabulary,
What about data?
be able to interpret clinical and operational outcomes through data analytics, understand what the data is telling them, understand the system development lifecycle, how systems are implemented from start to finish.
And the administrative side.
Yes, grasp the key administrative aspects like privacy regulations, security best practices, and fundamental leadership principles relevant to health IT. It's designed to provide that well-rounded foundation.
That sounds like a really valuable credential for someone established in the health IT field.
It's definitely well recognized as a benchmark of broad competency in healthcare information and management systems.
Wow. Okay, we've covered an immense amount of ground today. It feels like we've gone from a 30,000-foot view right down to specific roles and credentials.
We really have. From the macroeconomic pressures shaping global healthcare, that foundational WHO definition of health,
Through the different places care happens, hospitals, outpatient clinics, community settings, the complex world of payers.
the critical need for interrelationships and seamless information flow, enabled by technology and concepts like interoperability.
The diverse roles of the professionals making it all work.
Yeah.
CIOs, CSOs, HIM experts, clinical informaticists, the whole IT team.
Distinguishing between data science, health informatics, and HIM.
And finally, the governance layers, governments, regulators, associations like HIMSS, accreditation bodies, and certifications like CPHIMS.
It truly is an incredibly complex environment, isn't it?
Absolutely. And it underscores that from those huge global economic trends right down to the care of an individual patient, information and technology are just fundamentally at the very heart of navigating it all effectively.
Couldn't agree more. And what's really exciting, I think, is looking ahead. Advances in technology, particularly things like automation and AI, hold so much promise for continuing to simplify processes.
Taking some of the burden off the care providers.
Exactly. Freeing them up from administrative tasks, providing better decision support, ultimately allowing them to focus even more on the patient, making their vital work more efficient and hopefully more patient-focused.
That's a hopeful note. So as we wrap up this deep dive and considering everything we've discussed, the accelerating pace of technological change, the constant pressure on costs, the drive for better quality and access,
It leads to some big questions about the future.
it really does. So here's a final provocative thought for you, our listener, to consider. Given this increasing sophistication of health information and management systems, how will it not just improve efficiency or cut costs, but how might it fundamentally transform the very experience of well-being and receiving care in the coming decades?
Beyond just better records or faster appointments, what could that future feel like for us as individuals interacting with the health system?
Something to definitely ponder. Thank you so much for guiding us through this incredibly complex landscape today.
My pleasure. It was a great discussion.
And thank you all for joining us on this deep dive. We'll see you next time.